Imagine walking into your living room and seeing someone you have known your entire life, but instead of greeting them, your brain stops dead, overwhelmed by the immediate, chilling certainty that you are looking at a complete stranger. This is the defining reality of CAPGRAS syndrome, sometimes called CAPGRAS delusion. It is a rare clinical condition where a person holds the absolute, unshakable belief that someone close to them has been replaced by an identical imposter. Take a classic clinical vignette involving a patient and her mother. The patient will openly acknowledge the physical facts. She will confirm the woman in front of her has the exact same face, speaks with the exact same voice, and possesses memories only her real mother could possibly know. Yet deep in her gut, the patient remains 100% convinced that the woman standing there is a highly skilled actor, a clone, or a fake. The patient has not lost her general memory, and she can recognize other acquaintances perfectly well. This is a highly specific, targeted failure of recognition directed at the most familiar individuals in her life. When confronting with a symptom this bizarre, the immediate instinct is to write it off as a random primary psychiatric hallucination with no underlying logic. But clinical observation tells a different story. The delusion is actually the brain's desperate attempt to solve a severe internal paradox. That paradox lies in the patient experiencing perfect visual recognition, coupled with an absolute, undeniable absence of the normal autonomic emotional response that should accompany it. To understand how this happens, we have to look at normal facial recognition. Recognizing a familiar face is never a singular event. It relies on a dual pathway system in the brain, operating entirely in parallel. Deconstructing CAPGRAS requires us to stop viewing it as a pure delusion of the mind and instead map it as a physical, structural disconnection within this neurological system. We map this structural baseline on a cross-section of the human brain. Processing a familiar face requires two distinct neurological pathways firing off the optic nerve at the exact same time. The first pathway is the visual wire, the brain's face detector. Its job is analytical. It processes physical features, the geometry of the nose, the shape of the eyes, confirming a strict identity match. The physical description matches your left one. The second parallel route is the emotional wire, serving as the heart detector. This pathway bypasses pure visual logic and sends a signal straight into the amygdala. It generates that immediate, subconscious feeling of familiarity, warmth, and safety. It gives you the physical sensation of looking at someone you love. In normal physiology, these two pathways synchronize their data delivery perfectly. The visual cortex confirms the identity, the amygdala confirms the feeling, and they hand that data to your conscious mind at the exact same millisecond. True recognition requires both of these inputs. Structural verification must be paired with emotional validation. CAPGRAS syndrome introduces a localized failure within this dual system. The physical connection carrying the emotional wire is functionally damaged or cut. Notice the upper visual pathway runs perfectly. The face detector still confirms a 100% anatomical match. The person absolutely looks right. But because the lower pathway is severed, it delivers zero input to the amygdala. There's no warmth, no familiarity. The person standing there feels entirely wrong. The patient is fully neurologically aware of this agonizing sensory mismatch. They are physically trapped in a state where flawless visual data is dropping into an absolute emotional void. The burden shifts to the cognitive processing centers to handle this impossible dataset. Looking at this logic gate flowchart, we run into a strict neurological rule. The brain cannot tolerate cognitive dissonance or permanently conflicting sensory inputs. On one side of the ledger, the brain must acknowledge the exact physical match standing in the room. On the other side, it must account for the undeniable, chilling absence of any emotional connection. The central processor is forced to find a single logical explanation that satisfies both of these true yet conflicting variables. The brain outputs the only conclusion that neatly resolves the data. If this person looks exactly like my mother, but generates none of the emotional feedback of my mother, she must be a brilliant imposter. The delusion is an entirely rational deduction built upon broken sensory data. Understanding the mechanics leads directly to the next clinical question. What actually causes this physical and chemical disconnect in the brain? CAPGRAS rarely occurs spontaneously. As we build out this etiology matrix, we see it as almost always secondary to a preceding systemic or structural insult. The first highly testable category encompasses neurodegenerative diseases, making it a known complication in Alzheimer's disease and other progressing forms of dementia. The second major category is severe brain injury, specifically blunt force or penetrating trauma localized to the back and right side of the brain, where these recognition pathways run. Finally, the third category includes severe psychiatric conditions, most notably acting as a catalyst during episodes of schizophrenia or bipolar disorder. Forming a differential diagnosis across these three distinct categories is critical for high-yield exam preparation and real-world clinical practice. Pinpointing the specific etiology dictates the entire treatment plan, determining whether the patient requires a neurological intervention, surgical repair, or psychiatric management. The psychological toll of CAPGRAS syndrome is immense. It is agonizing for the patient experiencing the deception and devastating for the family members being labeled as malicious imposters. But explaining the two-wire theory to affected families provides a vital clinical peace of mind. It proves that the delusion is rooted in a mechanical disconnect within the brain's wiring. It is not a conscious emotional rejection by the patient. For your clinical practice and board exams, synthesize these mechanisms. Link the dual pathway mismatch directly to the three primary etiologies. Mastering these underlying pathophysiologies allows you to look past a confusing, erratic psychiatric presentation and solve the mechanical medical puzzle underneath it.